computers. Okay. So thank you all for being here. We're going to wait a couple of minutes. We had over 250 people sign up for this event today. So I just want to give us a couple of minutes to get people in the door here as people are joining us. Also, we have a wonderful program today. It's called After the Diagnosis, talking about transdisciplinary care, which is something that I am very interested in myself, and the work I'm doing somewhere else, but I just want to thank everybody that is on our panel. You'll get to meet them all in just a few minutes. And we are going to be starting with the program. If people want to put up in the chat where they're from, that might be useful. And also if you are doing work professionally in end-of-life care, or if you are a healthcare professional that's working with people that are ill and that this is particularly interesting to you because of those reasons, if you can put that up in the chat, that would be wonderful. And the brave soul that wants to start that is welcome to do it. Thank you, Heidi. Perfect. Oncology case manager, wonderful, Kay. Thank you. Super. So I'm just going to give this another minute. It's going to be beautiful. So we have a lot of people here that are working in hospice and palliative care. It looks like beautiful. Doulas, wonderful. Thank you. Great. So I'm going to start with our more formal introduction, and then we are going to turn this over to Connie and Donnie. You can nod your head. I also have a bio for you if you'd like me to introduce you with Connie, or if you'd prefer to do that. Okay, perfect. Thank you all. Oh, thank you all. So my name is Susan Barber. I am currently working for the Humane Prison Hospice Project, where we are bringing palliative care training into prisons in California, working with incarcerated people to have them trained up so that they can care for their peers within a hospital setting or a SNF setting or a dementia setting in the prison system. And that's my day job. My night job is I am the community education manager for the Elisabeth Kübler-Ross Foundation, and I get to curate wonderful events like this for people to learn more about death, dying, loss, and grief, and managing illness. So for those of you that may be here for the first time, I want to just say a little bit about the Elisabeth Kübler-Ross Foundation. We are a 501c3 nonprofit organization that was inspired by the life of psychiatrist, humanitarian, and hospice pioneer Elisabeth Kübler-Ross. Her son, actually, Ken Ross, manages the foundation, and he was very looking forward to being here, but was asked to do another speaking engagement tonight, so he won't be able to join us. The foundation was founded just 1 year after Elisabeth's death in 2005 by Ken Ross. And over the last years, the foundation chapters have been created on 4 continents. They continue Elisabeth's mission to develop hospice, palliative care, and grief support. And in 2019, almost all of Elisabeth's archives were donated to Stanford University, which will create a digital library to make her papers and her videos available to the public. She was a prolific author, having published more than 24 books in 44 languages. And Elisabeth, who I had the great opportunity to spend the day with, one wonderful day in my life, as much as she's known as sort of the death and dying lady, Elisabeth embraced life like almost nobody I've ever met in my life. She was an inveterate believer in people living to their last breath, and that people deserved a dignified and compassionate death. I also want to invite Connie, Borden, and Donnie Nelson. I'm going to spotlight them in just a minute, and they sort of are the brains behind today's panel. And I'm just so grateful for them and for the beautiful team of people that they've brought with them. Connie Borden is an RN, an MSN, and ANP, advanced practice nurse, with 28 years of experience in hospice and palliative care. She's led a local nonprofit hospice as the executive director. She's worked in inpatient services, a palliative consultant. Connie's presented advanced care planning information in annual interdisciplinary sessions during her 15 years at St. Mary's Medical Center in San Francisco. And she believes strongly in the necessity of conversations about healthcare wishes and strives to have this kind of conversation become a normal event across generations. And I love that sentence, across generations, because last night, my 24-year-old nephew and I had a long conversation about this. Donnie Nelson is a nurse. He is PHN, CPHN, a palliative care nurse manager at both St. Francis Memorial Hospital and St. Mary's Medical Center in San Francisco. In this role, he cares for some of the most complex cases and most vulnerable patients that land in San Francisco hospitals. Many of them suffer from homelessness, poverty, substance abuse disorder, in addition to their physical needs and their medical needs. He often talks about his experience working with patients and their loved ones coming to the hospital and the turmoil that results because they've never had a conversation about these unexpected things, which has led him to his passion for educating the community about medical advance directives. He partners with many of the local healthcare agencies in the Bay Area to facilitate advanced care planning workshops and to normalize conversations about what you might want at end of life or during complex medical situations. And with this, I am going to spotlight both Connie and Donnie, and they are going to take it from here. And I am going to disappear.
Okay, well, thank you, Susan.
Both.
I'm going to start and give a brief introduction to the concept of a transdisciplinary palliative team. Then we will have a little bit of a discussion from Donnie around palliative care consults. I'm going to present a case, and we are very fortunate today that we're going to have several therapists, social worker, physician, and nurse talking about this case in a transdisciplinary fashion. And then we hope by about an hour into the program that we will then be able to take questions, which I believe Susan will be managing mostly through the chat function. So we're glad to have you here. It's going to be exciting to see how many people join and the types of questions that come forward. So as I mentioned, today for our panel, we're having the unique ability to have many therapists joining us, physical therapist, speech therapist, physical therapist, along with a social worker, physician, and nurse. And we're going to be modeling how the palliative care team can extend beyond the traditional thoughts of a physician, nurse, social worker, and chaplain. We believe that each person with advanced illness is ready for a palliative consult. This is important as there is no designation of a palliative care patient. Rather, it's a patient who's had a palliative consult. A consult can be requested by patients and families to give an extra layer of support to the patient and family and help with anticipatory planning for the next phases of advanced illness. Let me just speak for a moment to contrast the types of teams that we probably have worked with. When we think about a transdisciplinary team, we want our members of the team to understand each other's roles, trust in each other's judgments, and build an advanced illness plan based on these full assessments. You've probably heard of multidisciplinary. Classically, you'll hear each discipline presents one by one to the requesting physician. Or you've heard of interdisciplinary, where people develop and their ideas into a coherent plan. But what we're striving with transdisciplinary is to integrate multiple fields of knowledge into a new way to approach the care or problem solving. And we hope that our team models these behaviors of communication skills, self-initiation, thinking skills that go beyond the usual, and social skills to allow boundaries to blur or dissolve. So you'll be seeing as we present a lot of interactive discussions between the team members who are adding and building on each other's assessments and the view of the patient as a whole person. So let me turn to my colleague, Donnie, who's going to say a moment to say hello to everyone and add a little bit more about palliative care from the trenches, so to speak.
Thank you so much, Connie. Hello, everybody. I was just looking in the chat and I have to say I'm a little intimidated. There is a lot of very accomplished people that are here today. I was thinking we were talking to the lay people, which is really easy. So I'm better mind my P's and Q's, but just a real quick definition of it. So, I mean, it sounds like everybody here has a good idea what palliative care is. And, you know, the way I like to describe palliative care is when you come into the hospital, at least when my team is doing a consult, it's almost like we're a concierge for patients who might be dealing with advanced illness. And it's not just the patient that we are consulting on, but actually it's the whole family is our patient as well too. And so we hope to highlight some of that in today's discussion in our case study. And so when we were coming together to try to figure out what we were going to say, I mean, we're always listening to the nurses and the doctors, I think, talking about palliative care, but palliative care is a team sport. We like to describe it as a holistic approach to medicine. And a lot of times in the hospital, I'm working with speech therapists. That's probably where I get my most many of my consults, but physical therapists, social workers have a huge part. And we happen to have all of my people on the panel today, they speak Chinese too. So they often work as interpreters for me as well too. So hopefully we'll be able to get to highlight some of that and how we would approach doing palliative care in a hospital, helping people make decisions about what's best for them. And
Donnie, did you want to go ahead and introduce the rest of the team? And if Susan can bring them up, we'll have then probably 3 or 4 people joining us on this. So the Zoom screen, our virtual conference room. You can visualize us sitting around a big conference room table, ideally with windows and light. And if anyone's participated in Schwartz rounds, a lot of this may sound very familiar to people as we go into our interactions around this case that I'm going to read in just a moment. Donnie, go ahead and introduce people and let them say hello to our audience today.
Certainly. So this is, it's my pleasure to introduce Dr. Nona May, and she is what we call the trifecta in critical care medicine. She is board certified in pulmonology, critical care medicine, and what's the third one?
Internal medicine.
Internal medicine. And currently right now, she is our ICU medical director, and she's also the chair of our ethics team, and she's the palliative care director for St. Mary's and St. Francis. So she wears a lot of hats, and she's actually one of my best friends. She's kind of my dream team with the doctors. If you ever get to work with a doctor who truly understands, we work so great together. We've partnered on a lot of stuff over the years. And then the next person I'd like to introduce is Joyce Liu. She's a physical therapist. So oftentimes when we're working in a hospital, we don't have like a big, in our little hospital, we don't have a team with a dedicated physical therapist, a dedicated speech therapist. We are lucky enough to have a dedicated social worker. However, if that patient is assigned to whatever therapist is for that time, if that's a palliative care patient of mine, then you are the palliative care physical therapist, or you're the palliative care speech therapist for that time. Anyway, so Joyce is a physical therapist. She's been with us for about 4 years, pretty much through the whole pandemic. And she has a passion for helping underserved populations as well. And then the next person on here is Lila Wong. And Lila has kind of helped me grow up over here at St. Francis. She's a speech therapist. She's been at St. Francis for about 25 years. And she's actually passionate about wellness. So not only does she do speech therapy and help out in the palliative care department, but she also does aromatherapy. She's a wellness coach, and actually she has a lot of products she's always giving me. And the last person we have on here is Micky Au. She's a licensed clinical social worker, and then she's our social worker in the palliative care department. She's been at St. Francis for about 10 years. And once I figured out how amazing she was, I stole her into the palliative care department from the care coordination department. So what's kind of amazing is she has all this knowledge and discharge planning. And then now I'm bringing her over into palliative care, and it's been a little bit of a dream team ever since then. So today we are going to go over a case study, and everybody is going to talk about highlight some of the work that they do. What's their input when we have a patient that comes into the hospital in this particular case. So I will turn it back over to Connie to do the case study.
Okay, so let's just imagine that we are a guest observer, either during or immediately after ICU rounds when the palliative care team has received a particular consult. So just imagine that you're part of this team and you're hearing some of the interactions and some of the developing recommendations. So that's what I want you to imagine for yourselves. So here's our case example. We have a 90-year-old Cantonese speaking woman with progressive vascular dementia. She has been admitted to the ICU for fever, lack of appetite, and lethargy. She has been given now the diagnosis of aspiration pneumonia. She has diabetes, high blood pressure, and she had a prior left MCA stroke. Her daughter, the eldest daughter of the family, has been caring for her at home for the last 2 years. This is the first time that this team is meeting a palliative care team. And as Dr. May was going to launch a bit more of the discussion, this is about day 2 of ICU, when the ICU team has identified their palliative needs that can be addressed by this team. So Dr. May, I turn it to you.
Thanks so much, Connie. And I'm so happy to be here and to be sort of preaching to the choir and talking to like-minded people that really care about taking care of patients and making sure that we're honoring their wishes. And as Donnie said, we are not just taking care of the patient, but we're taking care of the family and the people that care about this person. And so with regards to this particular patient that Connie has given us, this is a very typical patient that we would have in our hospital at St. Francis. And so I will say that, from a medical standpoint, as a physician, in medical school, we're taught to focus on the disease, right? We have to learn about how to treat this condition, what medications to give. And so as an ICU doctor, it's, that's our knee-jerk response, right? So my first thought about this patient when I think about her clinically is, well, what was her baseline function status before coming in? What was her medical condition and how was she doing medically before she had this episode of infection of aspiration that landed her in the intensive care unit? And then now putting on my palliative care hat, and more importantly, not just palliative care, but thinking about this patient beyond that disease, right? Beyond the aspiration pneumonia, beyond the stroke, the diabetes, who is this person, and stepping away from just that disease. And so I think this is when we think about palliative care and we think about, okay, we need to understand, is this, from my standpoint, the question I will answer for the family is, how treatable is this current condition, right? Is this pneumonia treatable? And what are the cost benefit analysis of this treatment, right? It could be very simple. It could be just some simple IV fluids, some antibiotics, maybe a little bit of oxygen, and she will turn around. But maybe that will not, right? And so I think, having this palliative care consultation early on is important. And I think a lot of people, and you guys probably know this, palliative care is sort of always seen as the dark horse, like, oh no, the doctors are calling in palliative care. That must mean that the end is near and we're giving up. And, patients and families oftentimes feel very abandoned. And so, and that's not what palliative care is, right? Palliative care is to address symptoms. Yes, sometimes, especially in the ICU, it is for patients with terminal conditions that are untreatable or irreversible, right? And so, but that's not, we want to make sure the palliative care team, as Donnie said, is like the concierge service. They are the navigator for that patient and the family from the beginning of the episode of being in the hospital to transfer or discharge to hospice, or potentially inpatient hospice if they're imminently dying. And so getting to know this family, getting to know the aspects, the nuances of this case is very important. I do want to say just a couple of things about how, as a physician, we approach these dialogues and conversations, knowing and understanding that a lot of families have this feeling of, oh no, what are they going to tell us? There's nothing left to do, right? And so I think a lot of the things that I focus on, and when we do training for other physicians and having these difficult conversations, is really changing that language, right? Instead of saying, do not resuscitate, we are moving towards, allow natural death, right? And the burden that I think a lot of families feel of having to say, okay, I'm going to give you the green light to the physicians to, I hate the term pull the plug, right? We really don't like to use that, but that's sort of the, a lot of people come in with these like, you're going to put them on a morphine drip and they're going to die. And that's not what it is. So I really think this concept of shared decision-making, which is a change and pivot in how we as physicians approach medical decisions, is very important. I think we come from, it used to be historically that physicians were a lot more authoritative, right? Whatever the physician said, we did, right? And then we swung to the side of saying, doesn't matter whatever the patient wants, we're going to let them have it, right? But I think more so in the ICU, this concept of shared medical decision-making is very important. And so the way I would approach this case would be, we would talk to the family, and from the clinical point, I would say, this is a decision that's going to be made by really 3 different parties, right? It's our medical recommendation as to what are the risks and the benefits of medical treatment. What are the chances of her pulling out of this, right? And what's the risk of her having this again, right? This is someone who has had a history of stroke in the past. who seems like already debilitated with progressive dementia. So perhaps this is the first time she's having an aspiration pneumonia, but this may happen again, right? So one aspect is the decision is my recommendation as a medical provider. The second part of that medical decision team is the patient's body, right? The patient's body and how they respond to the treatments we are going to be giving her is another way where it's that shared decision. And then thirdly, the family, the daughter, they can act as the spokesperson for this patient because they do not have a voice. So really, when we frame it in that way, especially when we say, the patient's body is really guiding this care, right? So as long as their body continues to tolerate this treatment, and these are the things we'll look for, we will continue it, right? And the family can tell us what the wishes of the patient would be if they would know what are the risks and the benefits. Are they going to tolerate being on the ventilator? Would they even tolerate wanting to be in the hospital in restraints or IV fluids? So I think giving it that framework of shared decision-making as we approach this conversation, this difficult conversation with the family, is going to be very helpful. And then as Donnie will ask our panelists to share with you guys, of course, having the input of all the other specialties to say, well, this is a whole person, right? So what is their swallowing ability? What is their mobility? What is their family dynamics? Who makes the medical decisions, right? With the Chinese family, it might be a little different than a family from a different culture. So.
Thank you, Dr. May. Where is this thing? So now we have the case, and I'm going to go to our specialist on the palliative care team. I'm going to start with our speech therapist, Lila. And so Lila, hearing this case, what would be your assessment and recommendations? How would you approach this?
Well, when I get a consult for dysphagia or swallowing valve, I always start with the chart review. So based on the chart review, it doesn't look like this patient is able to provide reliable information because of the dementia and lethargy. So I usually would start by calling the family even before I see the patient. Like Dr. May said, I want to find out what this patient was eating or doing before this admission. So, and also because Chinese family is very collectively dynamic, and all the decisions is not a single person's decision, but it's like a family decision. So it's good to involve the family as soon as possible. So in this case, I probably would try to reach the eldest daughter first, because she probably will have the most information about this patient's baseline. So I want to find out, the living situation. Is this person walking, even though it's more PT, but we do ask similar questions and we share some of the details so we can maximize care. And also want to find out this person's ability to hear or the vision and the communication. Like she already had a stroke. Was she even able to talk before? Does she have aphasia? And does she have any history of swallowing problem in the past? And if it is, what diet she was eating, what kind of food she was eating. So I do want to also find out the patient's food preference or allergies, just to get an idea of what I can offer when I see the patient. And also, I do want to find out if this patient ever had pneumonias in the past. Sometimes, they may have it like a long time ago or more recently, or if they have it, how often. And also, this patient ever was diagnosed with aspiration pneumonia, and the patient ever had like speech therapy in the past, and was a modified diet recommended? Were they following the diet? So there are a lot of questions. I think the daughter would be really helpful for me to find out from before I see the patient. So, and as I prepare to see the patient, I want to make sure I bring Chinese food. And in St. Francis, we actually have a really high Chinese population. Like on any given day, I think 20 to 30% of our patients are either Chinese and are Chinese speaking. So since I speak Cantonese, Mandarin, Toisanese, so I tend to get most of the Chinese patients. So it's important to provide cultural food. So I always make sure I warm up the food and liquid, because most of the Chinese patients, they will not drink or eat anything that's cold. So hot food and liquid is a big deal. And also juk, we want to have our rice porridge. So that's comfort food. So we're very lucky at St. Francis. We have juk pretty much all day, and you can get two types. You can get the puree juk, which is more smooth and easier to swallow, or the regular one. The regular one is a little chunkier, and it may be harder for the patients to swallow, but it's very similar to what they will eat at home. So I'll bring those in and see what I can do with the patient. So as I start my assessment, first, definitely we have to check for alertness. According to the chart, this patient is pretty lethargic. So if she's too sleepy or not arousable, I may not be able to do a swallow eval. So if she's alert enough, I can start with an oral mechanism exam. So just kind of find out, does she have any facial droop? Because she did have a stroke. So sometimes there may be some facial deficits already to start with. Or also I want to look at the dentition. Does she have missing teeth or dentures or something else? And also we want to look at saliva, like secretion management, because with aspiration pneumonia, a patient can get an infection from inhaling saliva, food, liquid, or something else. So sometimes patient can also aspirate by having saliva getting into the lungs. So we want to look at that also. So kind of look at overall all that, and if the patient is cooperative and alert enough, definitely the really important thing to do is do a really good oral care before we even start giving the patient food. So studies have shown that keeping the mouth clean is one of the best ways to decrease the risk of aspiration pneumonia and improve comfort. So it's really important to brush the teeth, clean the dentures, clean the mouth, suction the saliva out if needed, so that's really important to start. And after the oral care, and if the patient's alert enough, I can start doing PO trials. And with the solid, we'll probably start with the puree and then go from there, depending on whether or not the patient can tolerate. And the liquid, the same thing. If she's on a regular liquid, thin liquid, I may start with that, but if she's too sleepy, I may start with something a little thicker, just kind of test out, see if this patient can tolerate anything. So, and sometimes the first session may not be successful, then I may have to reassess to figure out what this patient is capable of. So
I'm so sorry. I know you're in your spiel. Someone was asking if you could explain what a PO trial was. So there's a lot of clinicians on here, I believe, but I think there's a lot of lay people too. So we're really trying to keep it on it. But, and when I'd love to hear about talking about the PO trials and how we're assessing this. And I really want to hear you talk about like what, we have a lot of discussions about comfort eating. Like we get to this place where we know that they have chronic dysphagia and they're going to keep aspirating. And then a lot of times our discussions really go into talking about eating for comfort and what does that mean and the safe technique.
Definitely. That's all on my little notes. So I'll get to that. So PO trials basically means like oral trial with the patient. So so typically we have like different food consistencies or textures. So a lot of times you want to start with the easiest, like puree, and then if the patient is able to do that, we may go to the next level. So the next level with the food trials is mechanical, is minced and moist, so kind of like ground food. And then we have the next level with soft and bite size, so things like cut up and then regular. So, and the liquids, they're different consistency of thickness. So it depends on what the patient can tolerate. I may try more or try less, I may have to stop. So definitely with this patient, again, I don't know if she's safe to be eating safely because she already is 90 years old with progressive dementia, history of stroke, and now with aspiration pneumonia. All those factors would affect her swallowing function. So great if she can tolerate something safely. If not, then studies have shown that tube feeding typically does not benefit patients' quality of life or quantity of life for elderly patients with advanced dementia. So that's when we, usually I always update the palliative care team after the eval, and if the status or patient status changes, I also like update them because we work closely together, very closely. Donnie knows, and I go to almost all the family meetings to kind of explain more to the family as well. So since alternative feeding or tube feeding is not really shown beneficial for this type of patient, so sometimes we'll recommend something called comfort feeding. So what comfort feeding is, we allow the patient to eat even though they're at high risk for aspiration and may not eat enough to meet the nutritional and hydrational status. But we want the patient to be happy and have pleasure. So we'll feed them slowly and carefully. And comfort feeding has shown that it improves comfort and the quality of life for this type of population, patient population. So, and again, once the family decide they may want comfort feeding, we definitely want to train the family as soon as possible. So in Chinese families, the patients and the families are very close. So it doesn't matter where the patient may end up going, nursing home or somewhere else, the family will be there and very dedicated to feed the patient. So some of the strategies for comfort feeding, of course, first we want to make sure we only feed the patient when she's alert and only when she wants to eat. And we also want to follow the diet that's recommended by the speech therapist, because we did an assessment and trying to find the diet that's the most appropriate diet, like the safest possible for this patient. So it's important to follow the diet recommendation. So also make sure the patient is sitting upright when possible, because that's more optimal feeding position. And make sure to give small bites and sips. A lot of times I would recommend for liquids, maybe just use a teaspoon instead of having, a big sips of water. So definitely follow that, like take small sips and bites, and also make sure you feed the patient slowly. Make sure.
Lila,
Yeah.
I'm so sorry. I know you're getting into your spell there. We've got a little bit of a time constraint, and I want to give all of us a chance to go on it, but we can go in and talk about the plan of care and how we would go about that and the suggestions that we would make.
Okay, I'm
to
so
the
sorry.
patient. Oh, no, it's totally
Okay.
fine. Like I could be here. I've heard you before in many lectures. So thank you so much, but we're going to get back to it in just a sec. So now that we have this case, I am going to ask Joyce, so what exactly does the physical therapist do working with a palliative care patient that we have, especially that is 90 years old, she's declining and doing these things? What's your assessment? How would you approach this?
Okay, so generally rehab therapists, we promote independence. Occupational therapy looks specifically maybe at how they can maximize someone's participation in activities of daily life, and PTs look at the mobility aspect. So in this case, like Lila says, I first do a chart review. Dr. May says she's day 2 in the ICU. So I look at the chart and consult with the team to get an idea of what's the medical picture here. And then, like Lila said, the family is usually very involved. So turning to the family is going to give me a very good picture of her mobility baseline. So like, how was she moving before she got to the hospital, what changed, and how the daughter helps at baseline. Sorry, I'm just reading my thing. So one thing I recognize is that, I'm meeting the patient and family at this one specific point. So how can I maximize the level of mobility that they still want to maintain and keep everyone safe, including the family, since they are a big part of she helps the patient, the daughter. So let's say after the stroke, she has right-sided paralysis. So at baseline, the daughter helps a little bit to get her mom into a wheelchair and then transport her to the bathroom and then help her mom get into the bathroom, providing a little bit of help. Now, let's say on my physical assessment, I find that she is requiring substantially more help, and it fluctuates depending on her level of lethargy or confusion. So this means I kind of have to ask the question of how safe is it for the daughter to be consistently helping her mom out of bed every time? Might it be looking at equipment like a bedside commode? Would that be safer to shorten the travel distance to the bathroom? Or might it be asking for another family member to be present and involved given how she is presenting at that time of day? Do we need to train that family member, or do we need to also consider maybe requesting from case manager that they need a hospital bed in order to decrease the physical burden on the family, depending on how she's presenting? Does it mean we need to maybe show them exercises to increase her sitting tolerance so that she can get stronger to consistently get to the bathroom, as it is that she wants and the family wants? So essentially, we're acting as consultants on this case. How can we still allow the patient the level of independence that she wants to feel like herself? How can we facilitate the family members to be able to provide that, but also be safe themselves? So it's kind of coming together to determine the level of care that they will need here, like right now, and also maybe within a week or whenever it is that she will go home. So we work together very closely with the team to decide what that picture looks like.
Oh, thank you so much, Joyce. And I think what's really important about when we're working with the patients and their families doing these things, like sometimes they might have a goal, but we're not able to meet that goal. And so then, you know, we all pull together too. Well, then we're going to have to readjust. We're going to have to maybe manage some of these expectations. And it's almost like a little bit of a, you know, we're starting to realize that there's going to be a new normal. There's a change. They might not be able to get up to go to the bathroom, or they might not be able to eat like they used to. And so what does that mean for everybody that's involved, the patient and their loved ones? I'm going to go over to Micky now. And so Micky, you did this 3 times today. So
I think
a palliative care social worker does, and how would you work with this patient?
Well, based on my experience as a palliative care social worker, I think the most important thing is to get to know and understand who my patient is. Like Dr. May has mentioned before, who is this person? Like, what was their life like before they came into the hospital? Where were they living before? How was their prior level of function? Who loves them, cares for them, and supports them? And also, what are their values and their wishes are? You know, where our hospital is located, we get a lot of unrepresented patients. If the patient is able to speak, I'll meet with them and listen to their life stories. But, you know, if the patient is not able to speak for themselves, I spend a lot of time, you know, talking to people in the community, their providers, their friends, their neighbors, family, reviewing records. So I get to know who this person really is and what is valuable to them. And so for this particular case study, what I would do as a palliative care social worker is to get to know this person, get to know this patient and her family. You know, if the patient is able to talk, I will talk to her to get to know her and her family more, find out how much she wants to know, and if she'd prefer us to just speak with her family. When I'm talking to the patient and family, what I want to assess is the patient's prior level of function with her activities of daily living, and what was her family supports like, as my colleague has mentioned before. You know, has the patient had any other hospitalizations with the same medical problem? Was the patient able to walk, talk, recognize family, and make her needs known at baseline? How much assistance did she need, and what does she need assistance with? And did the family have any trouble providing those care that is needed before already? You know, what is being shared can help provide us a better understanding of the disease process, the family resources, and how much the family understand about what is going on with the patient. I wanted to gather this information so our team can have a better picture of the patient and her family. The goal is to get a better understanding of how the patient was functioning before, the dynamic of the family, and what's important for the patient and the family, really. We wanted to know whether the patient was making her own medical decision, or does the family makes decisions together, which is very typical in a Chinese culture, but also sometimes the family or the patient has previously designated like one person to make that decisions. The case study mentioned that the patient has been cared for by her eldest daughter and the family in the past few years. You know, with Chinese family, there may be many children and grandchildren involved. I mean, we have done family meetings before where there were 20 family members. Our goal is to get everyone that loves her and wants to be involved in the decision making together. So I would help set up family meetings so then we can discuss goals of care. We wanted to have the chance to hear from them, but also for them to have a chance to hear the information all together and have a chance to ask questions. So then we're on the same page. And, you know, depending on what's going on with the meeting or what happens with the discharge planning, I would also assist with completing a pulse form, especially in Chinese, since I speak the language, so I can explain it a little better. In Chinese culture, oftentimes we don't talk about death and dying because it's being seen as bad luck or it's taboo. So many times we have patients that never had that conversation with their family before, and now that they're in the hospital and cannot speak for themselves, the family feels very overwhelmed because they realize that they never know what her wishes are. But sometimes the family, when families share those information and kind of share some information about her previous behaviors, can oftentimes give us shed some lights into what she may want and don't want and what she may tolerate or not tolerate. You know, for example, family let us know that patient never wanted to come to the hospital because they see it as very scary, or they stopped wanting to take their medications, or we've been told many times they're very stubborn and they don't like to be forced to do anything. So these statements can be very telling, right? And can tell us a lot about the patient. And another thing is when I'm looking at this case study, since the patient is in her 90s, if the patient and family is comfortable sharing, I also wanted to know if they have any other experience with another loved ones, possibly the patient's husband, being really sick in the hospital or possibly passing. You know, many times the family comes in and asks us, please do everything you can to save her or save him. And having these background information can really help us when working with them and also help them get to that place when the time comes. It's really very overwhelming for patient and family to experience their loved ones being in the hospital and having to navigate the medical system, especially when English may not be their first language or they have minimal medical knowledge. So our palliative care team is really here to help bridge that gap. We listen to them so they can feel heard, but also give them the necessary information so then they can make the most informed decisions that is the most appropriate for their loved ones.
Oh,
Now you guys know why we stole her.
I was told that.
I wanted to just make a couple comments, if I may, Donnie, on I think, you know, the theme that you guys probably heard from me and from everyone on the panel is that it's really important to get a baseline for the patient, you know, and I think oftentimes in the hospital, especially in the ICU, we hone in on the current problem, we want to solve it and then be done with, right? But what's great about palliative care is that, again, going back to that whole person-centered care, what is this patient's story, right? And so we rely on all our team members to get pieces of that story. Micky's right. Anytime a patient comes in, you know, I'm like, Micky, you got to figure out the dynamics. You know, families are complicated. We have families. We know how it can be dramatic. There's lots of, in our patient population, there's a lot of estrangement between family members. And if you don't really understand the dynamic of what's happening between this son-in-law with this granddaughter and this person in another country or somewhere else, and, you know, we don't know about that, it all comes out when this person is dying. And so if we have that information and Micky can go and suss it out and just, gauge that understanding and figure out who are the main players, who are, what are the dynamics playing here, it really helps us have that conversation with the family. So I think that baseline is super important. And then the other thing I was thinking about when Lila and Joyce were talking is this whole concept. I think as physicians, it's our obligation to explain to the families that oftentimes when patients come into the hospital for one problem, that one problem may be treated, right? So maybe she comes in with a pneumonia, and that pneumonia could be getting better, right? But as a result of being sick in the hospital, other things start to fall. And so it's not uncommon, especially in a patient like this who already has had a stroke in the past, she already has debility in her muscles, that this pneumonia in itself, even though the pneumonia has gotten better, her swallowing functions now even worse. And what I tell families is, hey, because they're like, yeah, but she's better, right? She's, you're treating her pneumonia, the antibiotics are working. Yes, it's working, but now we have a different problem, right? Now her muscles, including the swallowing muscles, are also deconditioned, right? And she's not strong enough to swallow food, which is very important. And maybe she already was not doing a great job of swallowing. And so I oftentimes will go back to Lila or her team members when they have done an initial assessment and say, okay, so maybe this is day 2. She's very weak and she's not able to participate or do very well with swallowing. But, as you continue to see her every day, what do you think her chances of getting stronger is from the swallowing standpoint? Or as Joyce, what do you think her chances of getting back to her baseline is? And I think that information, we convey that to the family, is also very helpful. But it has to be explained in the context of like, yes, this one thing is better. The first thing, the initial reason is better, but now we have all these other things. And that's something that we commonly see in patients who are elderly. And I think that's a very important concept for the families to understand and accept before we can even talk about, end of life. Because of course, this is their mom. You have one mom, right? And you want to maximize the quantity of life, but we want to also bring in that quality of life and make sure that, we're honoring the patient's wishes. And then my one last comment was about this concept of Chinese families and patient autonomy. This oftentimes happens a lot. I'm Chinese. I was born in China. And so a lot of medical decisions that are made in China is much more of a family decision, right? There are many times where the patients don't really even know their diagnoses and they're okay with that. And the family makes that decision. I think there's a movie recently that came out. Gosh, I can't remember the name of it anymore. It was about, was it?
They're coming home.
I think it's their farewell, something like that.
Farewell. Yes.
With Ali Wong.
Yeah, the farewell, because it's basically about a Chinese American who grew up in America, but she goes back to China to visit her grandma who has cancer, and everyone knows but grandma, right? And how she deals with this conflict of the Western, we're taught in Western culture in medicine that, it's a patient's decision, right? The patient has to decide what are their wishes. And we still honor that. We want to honor that. But how do you honor that in the setting of a culture that values the family deciding? And so the way that, Micky alluded to this, that we kind of try to honor both, is that, we ask the patient, if the patient's, still able to have that conversation, it's to say, how much do you want to be involved, right? Do you want to defer all these decisions and just go through your son, your daughter, your grandchild? Or do you want to be part of that, right? And so oftentimes, with Chinese families, the patient will say, yes, just talk to my son. Let him make that decision. They'll do whatever, So I think, understanding that dynamic and being able to tease that out is super important. But we love stories. I spent a lot of time in our ICU rounds, sharing background history and the story of this patient. Like one of our patients used to be an opera singer. You never would have guessed, right? All these patients that we see, when you have a story associated with them, it really humanizes that experience, and it brings us, it reminds us again in the hectic world of the ICU where we're, you know, like looking at numbers and, you know, doing all these things that, you know, this is another human being that we're taking care of, and they have family that care about them. And, you know, we're going to be here as fellow human beings, right? Who just happen to be doctors, nurses, physical therapists, you know, speech therapists.
Well,
So Donnie, you want to just sort of maybe pull the team together, show how you'll end up coming up with your set of recommendations that you'll be sharing back to the ICU intensivists.
I'm going to be doing that. Okay.
Yeah.
So,
Go ahead, Donnie.
it looks like we have a
Take
few
your team.
questions that are going on in
Yeah, let's take the questions in the chat after 6. I just want to wrap up the case
yeah,
example
absolutely.
to
So I
show
kind of
how
feel
you
like-
pull this team together to give a set of recommendations that tries to make a whole person plan.
So actually, I didn't say this earlier, but Connie is actually a mentor of mine. And when I started in this role, I mean, my background is ICU. So I didn't really get that much training in the beginning because Connie was working at a sister hospital. So I would be calling her all the time. What do I do? What do I do? And then Googling everything else before I was able to get some formal education on it. Though, but I think in this particular case for this patient, like once we're getting the family dynamic down, once we have a really good assessment of what their new normal is going to be, how they're going to function, and then also about their eating is probably when we would be coming together with a family meeting. And in that family meeting is when we would talk about goals of care. We're like, and I like to say with palliative care, I always want to talk about what we can do, not what we can't do. We always get such a bad rap with just always we're doom and gloom, but it's like, how can we maximize on quality of life with this bit of information, all this information that we got about this whole person that we're bringing together? And sometimes it might be hospice, sometimes it might be, you know, we want to get them better. They want to see how they do. And sometimes we send them home with home health. Sometimes they go to a SNF and sometimes they thrive. You can't always know. But this consult here and pulling this information lets us be able to make a better informed decision or help the family and the patient make a better informed decision about what to do next. So.
You want to just go back to your teammates and maybe they each have, and now they've done their assessments.
So we're at this point, and so Lila, I know you were talking a little bit about the comfort feeding. Now let's say we're going to comfort feeding. Like, what do we do? You're on mute.
If the patient choose comfort feeding, then we'll do a lot of family training, but we also make sure they understand that this patient can still be at risk for having pneumonia again, and also may not having the nutrition. So it's really important. When Donnie always really good about, you know, talk about hospice at this point. If the patient's not doing well, but we still, you know, choose quality over quantity. And I just want to end with something that for Chinese, food is really, really important. I think for everybody, food is really important, but particular for the Chinese culture is food is not just for nutrition, but it's for family closeness, for healing, for harmony. So from the day the patient was born, you have a party to the day the patient left this earth, there's another party. So food is like every step of the way. So so whenever possible, it's really important to respect the culture and the patient and family's wishes to allow oral eating whenever possible, to improve quality and comfort of the person.
Thank you, Lila and Joyce. So now we have this information. What would be your recommendation to the team and to the patient and the family?
So let's say she's showing potential for getting stronger with working with us. So we have a feeling that with continued strengthening that she would get stronger. And let's say they wish to take her back home. And so I guess while working in the hospital with us, we will try our best to simulate the specific setup that she would have in her home, since she probably have a very specific way of doing things. And we'll probably recommend, or we'll get the family involved during the sessions and work with them on like training them. This is the best way that we found helps to get her to stand taller, or this is the best way to like block her knees so she doesn't fall, or in case she loses her balance, you're right there to catch her. So we will do some training, and then we'll recommend any equipment that we find might be helpful to keep both the family and the patient safe, and probably recommend like ongoing therapy at home, home health PT and OT.
So let's say we're going home
Mhm.
and it doesn't look like she's going to be improving. And so a lot of times I feel like if we are maybe saying preparing for hospice or something like that,
Mhm.
what would be a recommendation for maybe helping with the family? I mean, do you teach body mechanics, that kind of thing? Like, how would we care for this patient at home if they weren't going to be able to move like they used to?
Yeah, so we would teach body mechanics. We would teach different ways of what we call like transfers, helping her get out of bed, to maybe capture one day she's able to do a lot, or one moment in time she's not able to do a lot. So we come up with alternatives so they feel like they have options and different ways to help.
Because I feel like we get a lot of patients a lot of times, and no one wants to go to a skilled nursing facility. You ever hear like, yay, sign me up for skilled nursing. But a lot of times if we can make it possible when we're doing this, we really, really rely on this information about how can we get patients home safely. And then, can we educate the families on how to care for them at home if they're gonna be at a different baseline than when they came in. And Micky, what's your input from social work?
So I think depending on what the family is ready for, if they decide that, let's say if they're not ready for, let's say if they're ready for hospice, they wanted to take mom home on hospice. We really wanted to find a hospice agency that speaks their language, speaks Chinese, and understand the culture. So then, they have a little bit more support at home and can understand their needs. If they're not ready to transition to hospice, and wanted to take her home and continue to see if she improves, what I would do is I would make a referral to a home health agency where they can continue to work with this family, whether it's physical therapy, speech therapy, but also a home health agency that possibly has a bridge to hospice, so that the nurse can continue to monitor how she is at home and continue that conversation with the family, and educate them on the symptoms of when she will be ready for it. Also, let's say if the family is not ready to take, when I do the assessment and I realize that they didn't have enough support, or they feel like they can barely take care of her needs before and now they definitely cannot, then we can also look into a skilled nursing facility, for hospice, or if they're ready for it. And if not, then a skilled nursing facility to see if they can get better, but also kind of talk to the family and also let the skilled nursing facility know that there may be a chance that she would be transitioning.
Yes, that's a lot of work when we're doing that. And I think a lot of times too, with a particular case like this is ideally where I like to introduce hospice and try to do it in a way that it's more of a soft sell. It's not like, boom, like this is it, you have to go on hospice, but we'd like to tell you about this service that's going to really help focus on your comfort. And so I see there's people from literally all over the world on here, and kind of what the trends I'm seeing when we talk about hospice is, that first time when a patient like this might come into the hospital, they aren't ready. People are really nervous. They get all this information. They're not able to make a decision at that time, whether it's the patient or the family. So sometimes as the palliative care team, we work with everybody on the team to maybe get them home or to the next level of care. But at the same time, we might do a hospice consult, and our practice is that we will do a hospice consult, bring in the liaison from the hospice and have them engaged in the palliative or the goals of care meeting sometimes, or just the meeting that we're having for the discharge. And sometimes they might go on to hospice, but if not, then our hope is that we do have a home health agency, as Micky pointed out, that has a bridge. And I think I'm seeing some new models of how this is going. We call it advanced illness management. And so some places are doing it, some agencies are not. And as we all know, that palliative care really isn't paid for outside of the hospital. So once that happens one day, I think we're going to be able to do better care. But those are some of the things that we're thinking of once we have all this information and we're coming up with a plan. And I think another thing that we do too, as the palliative care team, that isn't often is, I like to say palliative care, we're the one team that doesn't worry about lengths of stay in the hospital. And I feel a lot of times we're trying to, buffer our patients with that, but that's always in the back of my mind, is that when we're working with our patients, is that at some point they're going to say, can't be here in the hospital anymore. We got to kind of hurry up with some of these decisions. But I think the skill set in this is that, can we help this family come to a place of some kind of decision, and they're never going to know that ever happened. So I will stop with that. And if any of my team members want to add to that, if not, we can go to some questions.
And just see if Dr. May had anything else to summarize as the person perhaps speaking more directly to the ICU team. Is there anything else you would say at this point to them?
I mean, I think it's like, as I would be kind of like, usually when I'm in this role as palliative care, as my palliative care medical director hat, I'm sort of speaking to the, sometimes my colleagues who are taking care of ICU patients, sometimes the hospitalists, but I think the key as a physician is you really have to make sure the family is understanding what is the goal of care, right? So the recommendation from each of the team members, from speech therapy, from, physical therapy, from, would be different based on what the goals of care is. If the goals of care is, yes, the physicians have told the family that this is not a reversible condition, that she is going to continue to decline, and that the focus of care, the goal of care, should be on comfort, and she is stable to be discharged from the hospital for hospice, then we will go to the team and have recommendations on how to carry out the different aspects. But if the family maybe is still, they're not quite sure yet, and the patient's getting a little better, but obviously she's 90, so at some point this is going to come up, right? Then the goal would be a little different, right? So we would help outline the boundaries and the limits of care. So we could say, as long as it's non-invasive medical treatments, if she's in the hospital, we'll continue to see if she gets better, right? I'm very comfortable with being fluid with how the patient is doing and changing the goals of care based on the patient's condition. And I think that is an area where a lot of physicians probably don't do as much, because it is very labor intensive to have these dialogues. But I think it's very important for patients like this, who they come in and they have the dwindles, but sometimes they get a little better, and that's okay. If they're better, then we'll continue to treat them with the medical treatments that we have to try to reverse whatever underlying issue. But if they start to show maybe not going the right direction, not eating as much, and more of a consistent pattern of decline, then we will pivot and start to talk more about hospice or more comfort care and end-of-life care. So we've done that many times, where we've decided a patient, because they looked very sick, was going to be eminently dying, full comfort care, but they perk up. And then so we change it a little bit, and we try maybe IV fluids and antibiotics and medications, and then they may decline again, or they may get better and be discharged to a skilled nursing facility. But maybe on the second time they come back, the third time, now the patient's body is showing us, right? And at that point, the family may be able to accept that, because you have brought them along that journey, right? You've kept them in the loop. You are having this transparent dialogue with the family, with your multi-transdisciplinary team. And so we're all on the same page. So it's not a surprise. And so I think that from the physician standpoint is very, very important. And, I'm just really happy that we have such a supportive team to be able to collaborate and to work with the families and to make sure that we're doing the best thing and the right thing for the patients.
Well, thank you, Dr. May, Donnie, Joyce, Lila, and Micky. Wow, this was wonderful. The great comments coming in the chat. Susan's going to lead us through a few of them in a moment, but I do want to echo one of the comments about so holistic and caring was some of the messages that they've seen about your presentations and your thoughtfulness. Many people want to be, if they have to be in the hospital, they want to be in your hospital, in your ICU. So you're getting lots of positive comments. I think one of the things that I can answer before I'll turn it over to Susan, and we'll sort of round robin in the team, is that you will find palliative care in most hospitals these days. It is pretty common. You may not always find a team, and that's why this one's so beautiful, that is acknowledging the speech therapist, the physical therapist, the occupational therapist, the social worker, the nurse, chaplain, and doctor, but we're really seeing a full breadth of the services and the approach that comes in. So this is what I think was most unique about this team is that breadth. So yes, you will find palliative care to different degrees in different hospitals. We haven't even touched on finding it at home or in other facilities where it is very dependent on where you are in the country. But Susan, shall we turn it
Yeah.
over to you and you'll lead us through a few questions?
Yes, I have a question actually, and I'm wondering for your team, do you also use a spiritual care or chaplain type person for these discussions? And is that somebody that you might have at the hospital, or do you bring people in maybe? I know a number of hospitals that have actually gotten rid of that discipline. And for palliative care in particular, I would imagine that, I mean, I know it's very, for most people, whether they identify as religious or not, that spiritual component is very important to them, particularly as they are ill, when they're ill or nearing end of life. I'm just wondering if anybody wants to address that.
Sure. So we used to have St. Mary's and St. Francis, where Dr. May and I managed the palliative care team. We used to have two chaplain student programs, CPE, and I can't tell you what that stands for. So that would be 4 chaplain students. And I know for me over at St. Francis, what I do is I teach the chaplains how to do an advanced directive, do a little bit of advanced care planning. And our particular hospitals, the chaplains actually get the consults for if anybody wants to complete an advanced directive. So we do have chaplains. We have them 24/7 at St. Francis, but maybe not so much over at St. Mary's. But the other thing too is if somebody has a particular type of religion, I mean, we're not going to have any imam on staff per se, but we've had, you know, other clergy members. We've had a Buddhist monk come in before, like whatever our patients need, if we can get it, we're going to get it.
And are those, so that's, you have chaplains in the hospital, and are they part of the palliative care discussions for patients when you are coming up with like a plan of care?
Absolutely. I'll ask Dr. May to talk about our family meetings.
Okay.
With you.
Yeah.
Yeah, no, that's a great question. And I've worked at a lot of different facilities that have chaplain services. St. Francis, I'll speak to. We do, and we will ask the patients or families if they have spiritual preferences or they would like, you know, mission integration to come. And if they do, then we will absolutely include them. And the chaplains are great because they can offer that emotional, spiritual support, that extra layer, right? And not only do they support the families and the patients, they support the team too. We've had great chaplains that have supported our teams through very emotionally challenging times during the COVID pandemic, or when we lost a patient that we all became very close to. So yeah, absolutely. And there are times when for patients who have a certain religious preference, if we don't have, for example, there are patients that want their the anointment of the sick, Catholic. So we will reach out to Catholics in the community to invite them to perform those rites for our patients when possible.
Thank you.
Yeah, during the pandemic, I had to do it 6 times where I gowned up and did everything in the room, and we would have either the priest was at the hospital outside of the ICU speaking from his phone, and we'd have a big giant Zoom meeting and do that. And I would have to go in and actually do the blessing with the water. Just a little confession. We were going to have
Susan, do you want to go to some of the other questions?
Chaplain beyond this, but yeah, I'll go over on here.
Yes, I can take questions. I think Connie, you might be frozen. I'm not sure. But Donnie, why don't you finish with your thought, and then I'm going to go back to a question that was asked a little bit early, and then I'm going to get down to the questions that are most recently asked.
Absolutely. I was just going to say I wasn't able to get a chaplain to come be part of our interdisciplinary team, but we very much value chaplains as part of many of our conversations with families as well too.
Yeah. So there's a question from Nicholas. And he says, how do you help a family when everybody is circling around the conversation about death, and death might be near, but they are not quite landing on it? And how do you help or support a family?
Let me try first, and everyone can maybe share their approaches. Sometimes the fact that I'm Caucasian, I use as my perhaps in this particular situation, because I might say, I am not Chinese, I am Western medicine, and I'm going to bring up probably a difficult conversation. And can we have this conversation? And can we talk about what death and dying might mean in your family? So I will often acknowledge that I don't know of your culture. And then from there, allow them to explain to me. what it is that they are thinking or feeling.
Anybody else want to say anything?
Yeah,
about-
I think it's very common that we have families that have difficult time accepting the
Mhm.
death of a loved one, especially when it happens unexpectedly,
Yes.
and they are otherwise healthy. We've actually even had 90-year-old patients who come in. We ask their families how they're like, oh, they were great. But if you ask more, they weren't really that great, right? But again, because they are with them the whole time, to them, this is their baseline and they've been doing great. And so I think
Mhm.
a lot of the time is that whole part of bringing them along the journey and also acknowledging and validating that grief that they're going through, right? And to say, we understand, we also want these things to happen. We want her to get better. And we're also concerned that that may not be happening, right? Based on what we're seeing. And so how can we help you, help support you? How can we, honor your mom, your dad's wishes if we're not able to get to where we want, which is we want her to get better, right? So it's very challenging. It's very hard, but I think really just validating those feelings and where that comes from, which is the fear, the loss, the panic of like losing this person that you love so much, that drives a lot of that, right? And
Yeah.
so when we name it, when we say it in different ways, like, you seem like a caring daughter, we see that, right? She's lucky to have you, so all those sort of supportive statements can help. So
Mhm.
Yeah,
It's so
I
easy.
Go ahead, Donnie. Mhm.
agree. And just to piggyback on that a little bit is that Dr. May and I actually took some Vital Talk. I don't know if anybody else has taken that kind of training. I've done it off and on over the years. But one of the little tricks that I thought was amazing that I learned because I bombed it in the role play was, asking the patient's family, or if the patient can talk, but to the patient's family, like, how do you think your loved one is doing? And they might say like they're not doing so great, but you can align yourself with their way of thinking and saying like, I really want the best for your loved one else too. And of course, that a lot of times if that's what they're going to say, and then I'll say, but I have some concerns with a lot of the treatment that we're doing. It doesn't seem to be changing, or they're not going in the way that we want them to do. And so sometimes, and then just open it up with, can I talk to you about some of these concerns? And for the most part, you can go into that conversation about eventually they're going to die. I actually was doing that today. And when I asked if I could share some of my concerns, the patient told me no. So it's not always a win when you do that.
Thank you. Yes. Somebody's asked, how is palliative care paid for? Is it Medicare, or how is that if somebody is not on Medicare? How is that covered in the hospital?
So we're kind of a cost of doing business. I believe that physicians are able to bill for certain services. And I'll be honest, when it comes to this kind of thing, I know we need to be able to bill for it. So we're going to be able to pay for these palliative care teams in the hospital. I really think there's a huge need in the outpatient, as we were discussing earlier. But palliative care is really part of the cost of doing business for the hospital. But I will say that there's been a lot of research done where we show that palliative care actually helps with saving money for the hospital.
Mhm.
When we're doing these consults with families, we decrease what I mentioned earlier, lengths of stay. That means that when patients come into the hospital with a diagnosis, insurance gives it a length of time that they should be in the hospital. And at the end of that time, they have to go, and then the hospital gets penalized for not getting them better in that amount of time. It's terrible. But it's a little bit of a stricture sometimes that I'm thinking in my mind, because I don't think that people should have to worry about something like that when they're going through one of the most horrific times of their lives, especially facing this new normal. I think in the future, I'm really hoping that some of the laws are going to change. Hopefully CMS, that is Medicare and Medicaid, is going to catch up and understand how great palliative care is, what it does for patient care, and it's actually beneficial and helps with a lot of things that at some point they might start paying for it. How that would be reimbursed, I'm not quite sure yet.
Thank you so much. One of the things I really appreciated that was shared during the discussion of the case study, early on in my hospice career, one of the social workers met with a family, a Chinese family, where the dad was ill, very ill, and they met in the whole family was there. There was like 6 or 7 kids, and the questions, the eldest son actually asked most of the questions, and the social worker was really trying to have a conversation with the patient. So he engaged, he could answer some of the questions, and then she left feeling like, oh, he's going to come on board and receive hospice care. And then it turns out, like, she realized afterwards, because the son called back and said, oh no, we discussed this as a family and our families decided this isn't best. And so it was really sort of an enlightening moment for us to become, this was back in the 90s, much more skilled at being sensitive and showing up in an appropriate way for people in cultures that were not our own, and to really find out at the very beginning of the conversations, how does your family make decisions about things? Because she said I would have approached it so very differently if I had had an understanding about that. So I appreciate that. There's also some really beautiful comments. People want to come to your hospitals to have you be their palliative care team. Somebody asked, so many people are afraid of going into hospitals, and I think this is very specific to the hospital you land in. How can we spread the word about how caring palliative care can be? And I think that is an ongoing question that people in palliative care ask on a regular basis. Does anybody have anything they'd like to say about that?
I mean, I think just having platforms and forums and dialogues like this, right? And just educating ourselves, our colleagues, our friends, our family members about things you hear about, that's word of mouth, right? And I think when you guys were talking about being culturally sensitive, the thought I had was, what's so scary about hospitals is, not only do you have the interface of different cultures from different countries and, diverse backgrounds, the culture of medicine is a culture that is very frightening and very intimidating to navigate. And I think palliative care is sort of the advocate, the translator interpreter, right? It's that familiar face, for the family and the patients. And, when a patient comes in, we'll have Micky or myself or Donnie meet them, and they might not be ready for, hospice at that point. They may still be doing treatment to try to reverse their condition, and that's okay. But if there's an anticipated potential that maybe things could not go well, maybe the second or third time, at least when they come back, it's like, okay, we know them and we know the dynamics. And there's that relief that they have. It's not uncommon that Donnie and Micky, they get text messages still from families whose patients have passed, just to get that support. Donnie, I can say, I mean, he goes above and beyond. He's paid out of his own pocket to fly families in who can't afford to see their loved one at their end of life. We have a lot of patients who are unhoused, who have substance use disorders, who die alone and are estranged from their families. And so, it's really trying to build that bridge back and to give the families this last opportunity to see their loved ones, right? Even if they haven't seen them in 20 years.
Thank you. That's really beautiful. I'm not surprised by that Donnie does that, but it's so beautiful. I would say that is just so people understand, outside the realm of most palliative care programs. It's unlikely that in most places you would find your nurse flying your family out.
It's happened a few times, but I mean, sometimes, and I see so many hospice and palliative care workers on here, but like some of these stories you can't even write, they just break your heart. Like I cannot help but I just have to. And that's not just me. I think this whole team we're looking at right here feel the same way.
So Donnie, I'm just wondering if maybe do one last round robin with the team so they can say one particular pearl that either is specific to your discipline or the process of working in palliative care that you want to leave with our audience. So what is one pearl that you really want to make sure people know? Is there something you want to share? And I'll go to Lila first, because maybe she's been thinking about this. Do you have a pearl to share? You need to unmute yourself.
I think so I worked with Donnie for a long time, and before Donnie, I worked with Dana, who was before Donnie. So I think the important thing I want to spread the message to my colleagues is that anyone can make a referral to palliative care. So I've made a lot of referrals when I see patients with these difficult decisions, they have trouble swallowing safely, but tube feeding is not an option. So I just like want everyone to know anyone can make a referral. Could be family, could be patients, could be any one of us, even any of the therapists and nurses. It's very easy to do. And once the whole team is involved, it's just so much easier for us to kind of maximize the care for the patients and the family. So Micky and I work together a lot. We were able to send family to come in to bring food for the patient, and that really make a huge difference. So I would say anyone can make a referral to palliative care. So go for it if you feel like a patient will benefit from it.
That's great. And to speak to your colleagues and others, that's wonderful. Joyce, is there a particular pearl that you would like this audience to leave with from today?
I'm just very grateful to work with this team. I liked what Dr. May said about going back to the patient as really humanizing the experience, because I draw from that too. I like to get to know the person before, because there's a lot that we can do as therapists to really, it's not always about independence, but also just helping them feel like themselves, like what there are lots of things that we can do to really promote that. So I'm just very grateful.
And Micky, what pearl would you like to leave with this audience?
I think hospital are generally very scary. It's for patient and for family. A lot of times I would call when family get a phone call from a hospital, many times they're like, oh my God, what happened? It's something okay with them. And I think whenever I give them a call, I try to be very gentle, and I always, instead of saying that, I'm calling from the hospital, I want to ask these questions, what I usually started with is, I just wanted to get to know you and your mom or your dad or your brother better, or any of your family member better, and see if there's anything I can help with. And I think offering the help first, instead of just going straight in and asking a question, can really help build that relationship, even though I might know in advance that the conversation later with the medical team or anything is going to be very difficult, but having built that relationship ahead of time, and that they know that there is somebody on their court that I'm there to help, can really help provide them some comfort for later on when these difficult conversations do need to happen.
Beautiful watching everyone present their very best selves. Dr. May, you were bringing up pet therapy just there. Do you have another pearl besides the value of having a pet?
Yeah, but Penny wanted to make an appearance. I think I said a lot of things, so I will refrain from saying pearls, but I will just express sort of gratitude and feeling very privileged to be able to not just work with this team, but work in this field of being in the ICU and doing palliative care and really having that human connection. I think there are days when it's very emotionally draining, but there is also a lot of I don't know, it's a lot of fulfillment and contentment for me, and it really fills my cup to be able to have these experiences and to be part of these families and patients' lives at such a crucial stage, because we're all going to have it, right? We're all going to have end of life. And so I think it's really great to be with the team that takes that very seriously and sees it as an honor and a privilege. And also to be able to share our experiences of our little humble hospital with all of you guys who come from all over the world and share in this common goal and this very passionate sort of this drive to take care of our patients and to make sure that we're providing for the end of life. So thanks.
Thank you, Dr. May. Well, Donnie, I'm going to let you close us out here.
Well, this was amazing. And, when we planned this, I don't know how this was going to come out, but I am so proud of the people that I work with. And I think, I wish all hospitals did palliative care like we did. I remember Dr. May, when she first got here and we started working together, she says, we're kind of light years in some places just because we do so much with our patients. And I really think that it's about besides the medicine, besides these things, it's about us as a healthcare team making connections with these families, with these patients, and just really helping them get to a place of acceptance of whatever is going on in their life. The last thing I'm going to say is, I don't know if everybody recalls, it is National Healthcare Decisions Day Week month, which was on the 16th. And so I've been doing a lot of workshops. I think probably many of us have a platform about advanced care planning, and that really comes from doing so many family meetings and a lot of people coming in and never having this conversation. So if you don't have an advance directive, I'm endorsing that you get one. And whenever I ask my huddle in the morning, maybe like 3 people out of an entire hospital will have one. So I'm suggesting it here. So happy National Healthcare Decisions Day. And thank you so much, everybody, for letting me be with my team on here.
Thank you. I would
Thank
just
you,
like
Donnie.
to go ahead,
And
Connie.
Susan, let me just can I turn it back to you, Susan, and you can close us with what to expect next?
Thank you. So what I'm hoping we can expect next, but not immediately next, but maybe sometime this summer, perhaps Connie and Donnie could do a presentation on advanced care planning, specifically on advanced directives, POLST, why those are important. That those are instruments that are available to all of us in any state that we live in. Pretty much the POLST, maybe not in every state, but really important when you land in a hospital, especially unexpectedly. That people there, the healthcare team, understands what's important to you. And that's really what those documents are about. So I'll investigate that afterwards. But I do want to thank you. We've had people on here from Guatemala, from Brazil. We just had Dr. Obanjongla from Nagaland in India. So this presentation is going to be extraordinarily helpful for those people who are in the US working in end-of-life care or listening to this. And Austin and the Bronx. We've got it all covered here. So thank you all. And I also, this is making me feel like, gosh, I really should change my Medicare next year so I can land in St. Francis or St. Mary's should I become ill suddenly. But I do really, I so appreciate all of your expertise and the care just that you've demonstrated in this presentation. I can only imagine that it's exemplified a million times when you're with patients. So thank you all so much. I know it's a little past your work time. To all of you that are here, thank you so much. We are supported entirely on donations. So I hate to say that at the end of something, but it is actually true. I am going to put up a place just if people are interested in supporting the foundation, that there's an easy way to do that. And I just want to thank you all. We'll have another event probably in May, and this has been recorded, and so I'm not going to put up the donation page because I can't find it right now, but this has been recorded and it will be up on the Elisabeth Kübler-Ross's YouTube page hopefully in the next couple of days, and all of you will receive an email about that so that you can go back and you can share it with friends. We do ask, this is available for anybody to look at now. And thank the team for also giving permission to us for allowing to share this for a bigger audience. Thank you all. I will be sticking around here for a few minutes. I don't know that the team can. I just want to say, Dr. May, I'm going to turn off the recording now for everybody. And I have just one thing, Dr. May, I just wanted to say to you. So thank you all on behalf of the Elisabeth Kübler-Ross Foundation for your support of these events, and to our panel for their expertise and just the loving kindness that they have expressed today in this room.